Good afternoon, everyone, and welcome to today's webinar hosted by the University of Bath Institute for Policy Research, IPR, and Department of Economics. Thank you very much for joining us online. My name is Harry Rutter. I'm Professor of Global Public Health at the University of Bath. And tonight, I'm delighted to be joined by my good friend, David Buck from the King's Fund. He's a Senior Fellow of Public Health and Inequalities at the King's Fund. Before joining the fund, David worked at the Department of Health as Deputy Director for Health Inequalities. He managed the Labour government's PSA target on health inequalities and the independent Marmot review of inequalities in health. While he was in the department, he worked in many policy areas, including on diabetes, long-term conditions, dental health, waiting times, the pharmaceutical industry, childhood obesity, and choice and competition. So if you want to try and stump him during the questions, you're going to have to look hard to find a topic that he hasn't covered already. And he worked on all of those as an economic and strategy advisor. He's also worked at Guy's Hospital, King's College London, and the Centre for Health Economics in York, where his focus was on the economics of public health and behaviours and incentives. Today, we're joined by Dave in the first part of a new health policy webinar series organised by the IPR and the Department of Economics. He joins us to set out a perspective on population health, tell us more about the King's Fund's framework, and give examples of how it's being used in practice. Health and care policy is constantly changing, as we can absolutely see at the moment, with policymakers seeking to improve outcomes for the resources spent through many means. One current approach is to develop stronger approaches to population health. But what does this really mean? Why now? And how are approaches to population health meant to work? Will the experience of COVID-19 derail this emergency policy focus or intensify it? We're going to hear from Dave the answers to some of those questions now. Before we start, there are just a couple of housekeeping notes I'd like to share. First, your cameras and microphones will remain switched off, but if you have a question, please submit it using the Q&A function, which should be at the bottom of your screen. I don't know that we'll be able to respond to all questions, but we'll aim to respond to as many of them as we possibly can towards the end of today's session. The session's being recorded, so filming and photography is taking place. Unless we have any major technical problems, this session will be available later as a podcast and video in due course. So thanks again to everyone for joining us, and I'll now kick off today's session by handing over to Dave.
Thank you very much, Harry, and great to be here. I'm just going to share my screen and then we'll kick off. So, as Harry has said, I have a long history, so I'm really a jack of all trades, master of none. So hopefully you'll forgive me for not being a master in this field, but being very interested in population health and how that relates to the future of health and care in England. Now, for those that know the King's Fund's work and my work in particular, I do range far and wide, and so many of the areas that contribute to population health I will not touch on today, particularly the role of wider state intervention and policy. So the focus is really about connected to the NHS. And as Harry said, it really draws on, quite a lot of this draws on quite a lot of work that we're doing over the last 18 months to 2 years at the King's Fund, working actually on the ground with NHS institutions and critically their partners around different parts of the country. And we haven't really had the opportunity to share a lot of that work formally. We will be writing this up, and probably we'll be writing something more specifically next year, early next year. But it's really helpful for well, hopefully it'll be interesting to you, but helpful for me to put some of our work into a context and more of a structure. So hopefully you'll find that of some interest to you. And before I also start, I should say that a lot of this work has been led by my colleague Durka Dougal at the King's Fund, and me in conjunction with, as well as other colleagues at the King's Fund. So this is not, although I'm presenting, this is not clearly purely my work. So let's kick off. So the first question, I guess, is what is population health, which is a critically important question, and we can maybe get onto some of this in the Q&A about the distinction or possibly lack of distinction between a really truly comprehensive public health approach and a population health approach. And I think part of this is semantics, part of this is, I think, frankly, the right reason we use the term population health is to appeal to a broader audience than key public health professionals, because we recognise that whilst public health professionals and the public health discipline is really critical to the population's health, it cannot do it on its own, and it needs to engage much more broadly with those that others that influence the public's health. Hence the term population health. And there are various definitions in use, and this will probably be very familiar, not necessarily this specific definition, but certainly these what's engaged in it, what comprises it to many of you that are listening today, hopefully. So we define it, and we define it in the document on the right, the Vision for Population Health, which I'll come to say a little bit more about a little bit later on, as an approach aimed at improving the health of an entire population. And that's about physical and mental health outcomes and well-being of people within and across a defined area or population. And that could be local, regional, or national, and obviously those interconnect. Critically, whilst also reducing health inequalities. So yes, about average health of a population, but also the distribution of health within that population. And in our view, a true population health approach should include action to reduce the occurrence of ill health, action to deliver appropriate health and care service, and action on the wider determinants of health. And it requires working with communities and with partner agencies. So no one organization, no one part of the system, no one actor can do this on their own. And that's really, I guess, one of the key messages about our work on population health and how we're trying to support local areas and systems with the NHS, but between the NHS and partners to really make coherent progress at area level. Why is this important now? And this is really pre-COVID. We will come on to COVID, but the now here is actually also before COVID. And for many of you, this will be familiar territory, but it's important to re-emphasize this. So I think the first reason is that we know from a huge amount of work in public health and beyond that health is determined by many factors. But if you look across studies over different times, different time periods, using different measures and different methods, what you tend to find, although the details differ, can be reasonably significantly, there's a hierarchy of what determines a population's health. And we know from all of those studies in the round that the wider determinants of health are the most important. Those are the things that are the structures in our society, the power structures in our society, things such as housing, access to economic wealth and employment, etc., the most important, followed by the behaviors, the health behaviors that individuals happen to have, be that smoking, be that physical activity, be that forms of diet. Thirdly, by access to public services, including health and care services. And finally, our genetics. Obviously, that final one, these all differ. If you look at very specific issues, you can find this ranking may differ. But in the round, this is what really determines any population's health in a highly developed country like ours. Now, the pie charts are there because it shows that actually these proportions will differ over time and across studies, but that hierarchy tends to be, I think, true and established. But the final point here for me is that, and the key thing that really is to be in my bonnet about, is that healthcare organisations can influence all of these. Yes, they clearly are critical in delivering public services per se, but they can influence all of these determinants of health. And a well-focused, in my view, health and care system focusing on the population's health around it or within it needs to take action and can influence all of these factors of health, not just through the delivery of treatment services. And yet still, and I think this is changing, and part of our work is to try and help change this conversation. Still, we tend to think about the pillars, the 4 pillars of health, and we could argue about the specific definitions of these and the words in the circles, but generally taking that from the evidence, we know the wider determinants of health, our behaviours, an integrated health and care system, although others would, and we'll come on to this later, Greater Manchester thinks of that as public service reform as opposed to just an integrated health and care system. All of these things, combined with the place and community we live in and with, are the critical pillars that we need to focus on if we're really interested in improving population health. And yet the evidence is still broadly talked about, collated, informed, developed in silos, in one of these circles or another. The debates that we tend to have, the public debates we tend to say one's much more important than the other. Don't focus on that, focus on this. The interventions and the studies we tend to do tend to sit in one or other of these circles, and certainly the way that we organize our systems tends to sit in silos. And that's not entirely true, but actually it's largely true, is our contention. And that doesn't actually map onto the reality of how population health is produced. Furthermore, so there's something conceptual here, but furthermore, we know that what we're doing at the moment isn't really working. So this graph is probably versions of it will be very familiar to you, that we saw pre-COVID around 2010-11, a stalling in improvements in mortality rates across the UK. And that's not something that is just happening in the UK, but it is happening more in the UK than in other countries. Other countries have also seen a stalling of mortality rates, but we tend to be towards the bottom of the range. We also know, and this comes from some of our lots of work, but in our own case, work that we did for the NHS 70th birthday, that actually, if you look across the piece, the health outcomes that we have in England, and in particular England, but stands true for the UK too, are quite average. So whilst we do well in some areas and we do poorly in others, overall we're quite average compared to our sort of peers. And furthermore, we have widening inequality in health within England on some measure. So the answer to this is not just about putting more money into the NHS, although we would argue, and many others would agree with us, that the NHS is underfunded. It's highly accessible and it's a highly efficient healthcare system. So we do well in translating our resources into outcomes through the NHS compared to many other countries. But just putting more money into the NHS is not enough to address this. We actually have to think more about how the NHS connects to others and works around on population health as well as the delivery of treatment. So putting more money just into treatment is not enough to address this. But I want to be positive, because I think what's really critical is the NHS is a massive economic and social actor in our society. So how can we make the most of that in terms of population health? And that's, I guess, part of the work that we've been doing over the last couple of years, and developing in particular a framework for population health. It's in this document if you want to look for it on our website, and as all of our stuff is on there and free to download. If you do look at it, what you won't, this is the only technical bit in the whole presentation. What you won't find is lots of novelty. You won't find lots of new stuff. The King's Fund hasn't thought of fantastically bright ideas that none of you have thought of, or other people haven't thought of before us. What we've tried to do in this piece of work, and as I'm going to tell you, sort of like using this in the health and care system and showing it in the health and care system, is to bring some coherence to some of those areas that I've been talking about. How can we bring this together into a framework for population health that makes sense in a local, regional or national system? And what does that mean? So, and I'm very lucky to be employed by the King's Fund and highly paid to come up with having 4 circles initially, joining them together into a Venn diagram, which isn't, if anyone of you know, a 4-circle Venn diagram doesn't quite look like this, but nonetheless, this is our stylized image to help make that point. So our view, our contention is that a population health system is one about the balance between those 4 pillars of population health. And when I say that, I mean the balance of resources, the balance of effort, the balance of focus needs to be appropriate to the evidence that we know about what drives a population's health. And the second point is about paying much more attention to connections between the 4 pillars of population health. And if there is any novelty in our piece of work, that might be where the novelty lies. And so that piece of work, that report, essentially challenges, I think, the NHS and its partners to say, what is happening locally, regionally and nationally where these pillars overlap? And if you haven't got a good answer for that, that's a real problem, because that means you're focusing on your silos. You're not really engaging with the actors and those that can influence in your local system, however that is defined, in those other pillars of population health. And we, as we know as individuals, my health is determined by my housing. It's determined by whether I smoke or drink. It's determined by the people around me, and it's determined by my access to an integrated health and care system. And those things overlap. They don't happen in isolation. So our report goes on to argue, and I won't talk in great detail about this because we haven't got time, but what might need to happen next at local, regional and national level in terms of policies. And it has some important messages for resourcing, for accountability and for leadership. But what I am going to talk to you about, hopefully, is a little bit about when we've used this in the NHS and in local places, including largely with local government and voluntary and community sector. We've posed local places this very simple question, based on our contention about this being important for a true population health approach. What's in here for you? Do you know what's in this purple zone in terms of your policies, your practice, and how you resource your health and care system in conjunction with partnerships? And if you don't know the answer to that, then where are you going? And so, and what should you know? Where are your gaps? And so what we do in local places is really help people to map this for themselves, and then to help them interrogate and to hopefully move forward. So what I'm going to talk to you today about mostly is about practice as opposed to policy. And from all of that work, I think, and not just that work locally, but there's lots of other work going on which will come across here. I think there are 5 ways that the NHS has been thinking more deeply about population health, and there are many other things that I could have chosen a longer list, and I could have spoken much more about local authorities, and we probably will talk a little bit about them anyway in the Q&A, I hope, and the connection between local authorities and the NHS. But I'm just going to set out for you 5 ways that I think the NHS is moving forward in this sort of agenda, and then at the end come on to the potential implications of COVID. And just to give you a pre-warning, 1, I'm going to talk a little bit about integrated care, 2, about population health management, 3, about the NHS's economic impact, 4, about how some areas have really moved forward on population health strategies across place, and 5, about leadership. And about how critical that is, population health leadership, and what we've been seeing around that. And then finally, as I say, the reaction to COVID-19. So the first thing to talk about is integrated care in place. And for those of you that are not aware, integrated care is really the future direction of the NHS, and has been signalled very strongly in many documents, and the latest, the NHS long-term plan, which is about a year old now. And I think very positively, there's, as integrated care started, it was very much about, and understandably, very much about integrating or bringing together pathways of care for patients, largely patients with multiple conditions, so that the experience for patients and the outcomes for patients was much more holistic than getting one treatment here, one treatment there. It's treating people much more holistically, and that's a critical component of integrated care. But I think what's happened in the last year or two is that actually there's now a live debate about integrated care and integrated care systems, in particular those structures in the NHS and their role in place. And by that I mean that historically, many of you will experience this as individuals, and certainly if you're researching the NHS or in policy roles, the NHS has found it very hard to connect to others in local systems. It tends to look inwards, it tends to look and do things itself. And that's partly due to the model of health that is live in one in the middle of the medical model of health, partly due frankly to its size and its nature as a hugely complex system. But there is a debate going on at the moment about how can integrated care systems actually reach out in place into other partnerships and actually work much more strongly with those other actors in place. And there's a bit of a conversation, and this, again, you may see this as semantic, but there's a bit of a conversation about, is the NHS reaching out, which is essentially integrated health and care systems and those in charge of them, seeking to do more on the wider determinants of health, do more on health behaviours and lifestyles, do more with communities, versus, and versus is probably too strong a word, but versus plugging in. So actually the recognition that there are lots and lots of other people in local places who are working very strongly and very, very hard in these pillars of population health and in these sectors. And actually what integrated health and care systems need to do is plug into that activity as opposed to reach out to it. So you may see that as semantic, but I see that as really critical, in the sense that plugging in is, to my mind, is much more humility. Actually, it's recognizing the contribution of those other pillars and those other actors in those pillars of population health, and saying, what's our contribution to you, as much as what can we do ourselves. But the positive thing to say is that this is a live debate about the future of integrated care systems. It is moving beyond simply the delivery of, although the critical, necessary, of integrated pathways of care. What are our organizations and our systems' role in a much bigger world of population health? So that's the first thing that is happening. And one example, it's not happening at the same speed or in the same way in any place, but it is happening very locally. And one of the ones that you might be interested in following, if you haven't already, is West Yorkshire and Harrogate Integrated Care System. And this is just a screen grab from their website about some of the things that they are doing. And they've got a population health team there whose job is to connect with all those other partners in that place. And so I'm not going to go into detail here, but these are just some examples. You wouldn't necessarily have expected a largely NHS driven organizational partnership to do a lot of work on housing and health, for instance, and yet they are, and they're saying what's their contribution to their local housing problem. They're also putting money towards voluntary community sector organizations to focus on health inequality. They're doing a lot more than this, but just to say that this is a focus of work for many integrated care systems. So that's one area where we need to support and push further. Second area, I think, is PHM, and that, for those that don't know, that's population health management. And this is really about the data that the NHS holds. And again, it has started very much looking actually to the United States and accountable care systems in the United States, who have a much stronger handle on data about patients and connected data than perhaps that we do currently. And so this piece of work, which has been led by NHS England and Improvement, has been about really understanding the data flows in the NHS. But again, two things. One is a lot of these pilots are now moving towards data flows, the shared data about people and about place connected to local government services in particular and voluntary community sector organisations. So seeking to reach out and to understand how healthcare experience is intimately reflected by the experience and the information that we have about people's lives more generally. And secondly, that in my view, it started very much as, again, a care pathway approach, but increasingly population health management is looking towards connect to a wider local vision for population health. So population health management, I see, and all the data flows and the information could help provide the glue for a much broader population health approach in place. And if you're interested in this specifically, we're running a whole day summit with NHS England and NHS Improvement on the 2nd of December, which is free to join. So that's my advertising. So if you want to join up, look at our website, and we'll hopefully hear more about some of these examples, particularly in relation to inequality reduction on the 2nd of December. So I think that's really critical and important for probably the NHS is taking very seriously data connection, but beyond itself, with partners and connected to stronger vision for local population health, as opposed to just understanding and improving pathways of care within the NHS. The third example, and many of you will be aware of this already through a lot of work on anchor institutions, which is developing, and I see this as a really critical part of a population health approach for the NHS, is the NHS is starting really to take its wider economic impact more seriously. And this sits for me on the left-hand side of the diagram here, this slide here, is the connection between an integrated health and care system, the wider determinants of health. And I think this has changed, so that's certainly the last 5 years. But 5 years ago, if you were to say that the NHS was a wider determinant of health, you'd perhaps be looked at rather oddly, because these are separate worlds. These are separate. The wider determinants of health is this world, the NHS is that world. And actually, there was a lot of debate about we need to focus on one or the other. Now, I think what I see as a much more mature approach is now actually the NHS and its leadership has widely accepted that it is a massive economic and social player in every place. And more than that, it's more important economically the poorer you are. So the further you go up the country and the further east you go, the larger the proportion of gross value added, or as economic activity, however you choose to measure it, or employment, however you choose to measure it, the NHS becomes. So there's both something really positive about this and a real expectation on the NHS for me that no matter what its budget is, it needs to maximize that economic effect in its local community. And the diagram on the right is just a very simple diagram from a piece of work we did about 5 years ago for the Joseph Rowntree Foundation on the NHS's impact on tackling poverty. And very simply says that the focus that most of us tend to, in health policy world at least, tend to focus on is the direct relationship between the NHS and health in the black box. But actually, if you step back and think about it, it has these much broader impacts on health through poverty or impacts on economic circumstances of people, through its commissioning, through its employment, through the fact that it delivers benefits in kind. It has an impact on income distribution, and that impacts on poverty or wider determinants of health. And then that further impacts on the NHS itself and on the demand for healthcare. So if we take that approach and think about that, then the NHS has a much wider role in health than we actually think about, but we've got to be intentional about that and realize that. So one of the statistics that really got, or two things that really got me about this is, once there's a study from the OECD about 10 years ago showing that income inequalities would be about 15% wider in the UK if we didn't have an NHS. So the NHS actually squashes income inequalities by existing. So that's a benefit to health inequalities if you accept the relationship between income inequality and health inequality. So just by existing, it does that, just by being an institution. And secondly, we know that, and although this is where an area actually, for any economists listening, I think we could do some really further studies on this, is that if you look at fiscal multipliers, then healthcare tends to be quite a large fiscal multiplier. And there have been some studies in the UK of this, but not very many, sort of fewer than I would expect. There's been a recent study in Wales about the effect of the NHS in Wales as a fiscal multiplier. But I think that sort of recognition is really important, and we should both celebrate the fact that we get that through our NHS, but also challenge the NHS to be more intentional about what the impacts are of that and to maximise them further. And I'm pleased to say that I think these ideas are becoming much more mainstream than they were. So the box on the left is a recent publication from the NHS Confederation, which is an alliance of key NHS organisations, really reflecting the role of health and care in the local economy. And the box on the right, it refers to the Shelford Group. That's the 10 of the largest acute hospitals in England, which together employ about 140,000 staff. 2/3 of the country's NHS research infrastructure, about £12.5 billion of the NHS budget. They recognise that they have a role as an anchor institution, as an economic and social institution in their own places and in the economy. So I think there's lots of mileage to go in actually really maximising the impact of the NHS, and we have to understand it and we have to be intentional about that, and that can have a huge impact We were doing some work recently for NHS England, again, revisiting that work on poverty and the NHS. A really interesting point from the South, I think somebody in the Southwest saying, for instance, in Cornwall, you know, Cornwall has a very strong tourist industry, but it's only there six months of the year or so. How can the NHS be a proving ground or a place where people who are employed for 6 months of the year can then go and gain skills, volunteer, or be helped on training pathways in the NHS for 6 months of the year? How can the NHS be more proactive in supporting the local economy in that way? And there are examples of that happening around the place. Fourthly, I want to say, so there are areas where the NHS, I think, can be much more positive and take more action, and that will improve population health, regardless, ignoring its treatment role. I think this is a really good example. Many of you will know about Greater Manchester and its devolution deal from George Osborne. We have been working in Greater Manchester over the last 18 months or so, and there's obviously been a stall for COVID, but really taking our report, and also in combination with another report we did, which is about a role of cities in population health, was looking at other international cities and saying, what can we learn in England about how cities can act at city level on population health, and really applying it to Greater Manchester and working alongside them to help them think through their population health system. For those that don't know, Greater Manchester is an area of 10 local authorities, about 2.8 million people. So it's not just the city of Manchester, it's many of the areas around it too. And they took our framework and adapted it for themselves, which is fantastic. So you'll recognize on the left quite a lot of similarities, but also some differences. So as I was saying, our focus on integrated health and care, because of who we are as a healthcare organization, not healthcare organization, but a health and care focused organization, very much focused on integrated health and care. In Manchester, they're really interested in public service reform much more broadly, so including health and care, but also other public services. And also slightly different focus on the right-hand side about place-based and person-centered approaches. So that works for them. But we were working with them to look across what they were doing in Greater Manchester, across all of their policies, about how we can actually tweak their approaches to be more population health focused. And the list on the right gives you some of that detail. So I won't go into detail about that, but it was a really fascinating example about a system at a regional level, really reflecting back on itself about what are the key things that it can do, including the NHS, but connecting that with the rest of the system. And my final example really is about underpinning. So I think one of the underpinnings is what I was saying about population health data management and the role of data in supporting a population health approach through the NHS in partnership. The second one for me is leadership, and Harry will know this much. This is why I'm a jack of all trades, master of none. Harry will know far more about leadership and particularly complex systems than I do. But from our reading of the research, clearly a population health approach is about influencing a complex system, and we know that actually leadership is really important. So we've looked at some of the evidence for what does leadership mean in complex systems, and how does that translate to a possible population health system, particularly at local level, but also regional and national level. And these are some of the things that we think are really important. And this also came from our learning from what seems to make cities that seem to be doing well on some aspects of population health, what might help explain that. So the first thing is the ability actually just to recognize that while you're working hard in your particular bit of the world, there's a lot you connect and plug into a much larger drivers of health and population health in your place, however that is defined. So actually ability just to see your place in a larger system is really critical and to recognize that. A corollary to that, and this is sometimes where the NHS can struggle, is the ability to be reflective about that. And actually the solution to many of my problems lies in other people's hands and other bits of the system. Not all of the solutions lie with me. And therefore my role is partly to support others as opposed to just deliver things myself, and that sometimes the NHS can find that quite hard to do, and the leadership can find that quite hard to do. Third, the ability to shift the focus from always dealing with the day-to-day to thinking about longer term. We know that's really tough for anybody, but that's really critical to create the space to do that, to reflect about that. Fourth, the really critical importance of political engagement and soft power, particularly even in Greater Manchester. We looked at Greater Manchester compared to London about governance for health, public health, etc. And London is very, very complicated. Even Greater Manchester is complicated. So the ability of soft power to cut through complex governance between organisations and bits of the system and appeal directly to communities is really important. And we may have seen some of this in obviously COVID response and the role of mayors in particular in Greater Manchester, but not just in Greater Manchester. And that signals a stronger and a strong role for soft power. And fifth, and by no means least, is actually having some resources that can coordinate and help guide action across organisations and systems. And it doesn't have to be a large amount of resource, but it needs to be there. And that's some of the learning that we got from our work on cities and population health, was that those cities that seem to be successful actually can carve out coordination resources. So for instance, Amsterdam on obesity, but also other cities. And this is one of the pieces of learning that we presented back to London. We did a piece of work for the Greater London Authority. We didn't do it for them, but we did a piece of work looking at London and said, actually, you need to carve out some stronger, some resources for coordination with public health people, but more than public health people to coordinate. So leadership in complex systems, in our view, needs these elements. These are critical elements. And we've been doing quite a lot of work over the last 18 months, 2 years, with places in England and in Northern Ireland too, to actually support and develop leaders from across the NHS, but critically also with those partnership organisations, with local authorities, with the business sector to some degree, with voluntary and community sector certainly, to help support their own goals in developing their leadership cadre to understand and be confident in those 5 key things as well as others. So, and these are just some examples that we've been involved in. And the final piece is just the final slide image at the bottom is so most of this has been place-based, but that is something that we do at the King's Fund, specifically invite people to the King's Fund to do it. So in my view, you can all of these things are important, but the leadership and the confidence to see yourself as a leader for population health, no matter what organisation you work for, is really critical to this and really critical to success of a population health approach and it's sticking. So I've been through 5 things. I guess the big question is one big question is what next? So COVID-19 is clearly here, and there are many pieces of work about the impact of COVID-19, and it's hard to summarize that impact up and doesn't do it justice, the impact in one slide. But this is my one slide that I continuously look at. This is about the impact of COVID-19 on inequalities in health. And as many of you will know, we have one of the widest inequalities in health in a developed country as it is, and that's the grey bars here. But what COVID-19 appears to have done is really exacerbate that, particularly in the 30% of the most deprived populations in the country. And of course, many other factors too. Black and minority ethnic populations have suffered in addition to this, and there's lots of debate about why that may be. But COVID-19 has really, I think, awakened people to the impact of inequality, in particular in health. And that has had an impact on the NHS, I think. And the reason I've put these slides up is partly because it talks about health inequalities, partly because who this slide is from, with the Director of Strategy in NHS England, NHS Improvement, and the connection to NHS recovery after the so-called first wave. So I've been around the block a long time, and I guess since 2010, I haven't seen the NHS as serious about health inequalities as it is now. And as COVID-19, the recovery in this sense is how does the NHS recover and get services back on track for patients. And our health inequalities is one of those really critical key aspects of this. And I think that's unfortunately quite unusual for the NHS, but it's really seen the impact of health inequalities, both at national level and also at local level. And I'll talk a little bit about that in a minute. So COVID-19 has really re-emphasized health inequalities front and center for the NHS and how it does its business and what its role is. And I think this connects to the population health approach too. Also, you don't often see, or have not often seen in the past, the connection between the NHS and wider determinants of health, the connection that I made, particularly around anchor institutions, etc., but it's there more broadly. So this again is a connection that the NHS's leadership, and when I say leadership, I mean national leadership, is seeing and taking much more seriously. And that is very positive again for a true population health approach, as long as it is followed through. And so I think what the NHS may be aiming for, or could aim for, is more of this. And that's both, I think, because we've been on this trajectory for a while anyway, and I think the intensification and the realization that has come through the understanding of COVID, and particularly the impact on inequalities on health. And for those of you that haven't heard of the Montefiore health system, it is a US-based health system, and we are not suggesting that we switch to a US-based health system, far from it, but this is a health system that within the context of the US system is become a much more strongly integrated institution, both in terms of delivery of care, but more importantly for me, in terms of its integration into the wider pillars of population health and its role in its place. So I won't go into detail about this, but I would love to see us or anybody else writing a piece of work about a UK part of the healthcare system, a UK place which has really taken forward population health in the way that Montefiore health system in New York seems to have managed to have done. So again, if you're interested in that and what that means, that there's more of that on our website. So there's a long way to go, but I think, and this is the local bit, as NHS organisations were starting to emerge from the first wave of COVID during the summer, we've been approached by several of them, particularly large trusts, coming out, reflecting on their experience and realizing two things. One is the tremendous impact it's had on their communities and of course their staff, but also seeing the realization this is a real push for us to actually, that we need to take a much bigger role in population health in the way that I've described, not just in treating patients as they come through the door. So I think there's a real desire from the NHS to really operate and step up in the way that I think it can, and it's been starting to do, but to do it much more systematically. And we've been supporting some organisations to do that. So there's some optimism here. And I think COVID has actually, and we've also been doing work with clinical leaders too, for not the organisations, but clinical leadership generally, who also recognise this. But there is another but, and a big but. So whilst COVID has shown just how important a population health approach is, and has driven, in my view, a much greater awareness of health inequality and the wider impact on health, and also the community-based medicine. I haven't really talked about that, but around the role of volunteering and the role of communities more generally. We've been doing some work actually with the Directors of Public Health, and we've been hearing really amazing things about how they've managed to help work through and with their communities around the COVID response in a fantastic way, and we'll be publishing some of that later on, probably next year. But it doesn't surprise you or anybody else that the NHS, like other parts of the public sector, is under extreme pressure in terms of capacity and workforce, and preparing for the next wave of COVID-19, which we appear to be in, and that the backlog of treatment is building up. And we hear more and more of that in the media about waiting times and people's, unfortunately, operations and other treatment being cancelled. So there's a big question about, will this opening up, will this population health approach survive, versus narrowing down and focusing on basically just treating that backlog and just doing what many in the NHS would see their core business. So I think there was a big question about that. I hope, and it could go either way, and it may go either way in different places, but I certainly hope that coming out of COVID, we, and when I say we, I mean myself and all of you, need to continue the health and care system to really understand its impact in the broader sense, and the many ways beyond providing treatment that it can affect health, and that actually it can make an even greater contribution than it does to the health of populations beyond treatments and beyond the patients that it directly serves. And as important as that is how it influences health indirectly, and through some of the routes that I've hopefully shared today. And that's my hope and my optimistic hope, I guess. And we certainly, the King's Fund, are very keen in helping the NHS to do that. So I think that's probably enough from me. So happy to hand over back to Harry and any questions, if there are any, and I'll stop sharing my screen too.
Thanks very much, Dave. That was really fantastic. We've got a few questions and they're rapidly increasing in numbers, but we'll start with one from Mike Leaf, who came in first of all, who said he hasn't had any reference to asset-based approaches to population health. There's a big focus on deficits in the NHS, but what about assets? Has there been any consideration of that in your work?
So thank you, Mike. Yes, so I haven't had time to talk about that, but absolutely. So recognise the asset-based approaches to population health. And I think that's probably coming out more, as I was saying, I referred to some of the work we're doing with Directors of Public Health. So we're doing a piece of work funded by the Health Foundation, actually understanding the contribution of Directors of Public Health and what they've been focusing on in their places, in their responses to COVID-19. And that's both the direct role and, in critically, the long-term effects of COVID-19 on their populations and population health. And it's been really interesting. So a lot of, not all of them, but a lot of Directors of Public Health, it's too simple to say they've gone in two directions, but one direction that they can go into is to really engage with all the structures and decision-making and governance in place. Another direction is to work much more directly with their communities. So for instance, some of them have been very, very strongly focused on supporting their communities around COVID, but much more broadly, including through asset-based approaches to population health. We're also doing some work, or hopefully, we don't know yet because we don't know whether they're going to get funding for it, but looking at does community strength or community resilience in some way predict the long-term community outcomes from COVID, the experience of COVID-19? What do we know about that? So absolutely, I think community approaches to health more broadly, of which asset-based community development is one, of which volunteering is another, have been really critical. And we've heard we saw the huge response through the volunteering route, and we're seeking to understand that. There's a real question for me about should we be, and I don't know what the answer is, trying to convert that huge response into a long-term stock of goodwill and assets for particularly volunteering around health and care, or should we just accept that it was a one-off response from the public? I don't know the answer to that, but it's a really interesting question. And broadly, sorry, we're going to do another question, but broadly, the King's Fund's, just to say, the King's Fund's strategic focus has recognised that actually healthy communities and places needs to be a stronger focus for us at the King's Fund. So we will be doing more work in that space as an organisation, not just me individually.
Great, thank you. We've got quite a few more questions appearing now, so I'll speed you up a bit. The next one is about, from Connor Parks. You discussed how COVID-19 compounded the issue of health inequality within the UK. Has this pandemic simply accelerated the need for action on issues that needed addressing anyway? If so, how does the reform look for a system that's able to be proactive rather than reactive to components of health in the UK?
Good question. So my short answer is yes, I think largely, not solely. And so I think one thing is that there's a question about how much this is national, how much is local. So I think one of the things that's come out of COVID-19 is a strengthening of the local hand and recognition of that local places possibly can take more control. So there's a point about how much do we focus effort on the national response versus the local response. And I hope that a population health sort of frame, not necessarily ours, but a sort of framework can help local places certainly in the absence of or alongside national responses actually focus much more on inequality reduction. And that's why I'm optimistic about the NHS. The NHS is, I think, was starting to recognize this role much more strongly anyway, but I think COVID has enhanced that. And so what all of we can do to keep talking about that, keep supporting, I think would be really important so that we don't slide back.
Great, thank you. Matilda Allen, who wants to thank you for a great presentation, and it chimes with a lot of what they've been hearing at the Health Foundation, said they've heard a lot of frustration that there is an increased NHS centralisation, for example, with procurement rules, and that this hampers local determination and resourcing for anchor and other activities. Which echoes a question I was thinking about actually, which is about the national local balance. I mean, we've absolutely seen this with test and trace, but there's a whole set of ways in which there is a power and economic financial imbalance between national and local. And I think something a bit more about that would be really helpful to hear.
Yeah, so again, that's a really good point. I think one of the things that COVID did do, my experience was that it broke some of these barriers down in the short term, because everyone thought these sort of rules and regulations, we've just got to get on with it. And I think Matilda's right, in local systems, that's what also is, let's not go back to that past. Let's settle somewhere else. I do think integrated care potentially is a vehicle for this, because that is about local power. The thing that I worry about, if I do worry about integrated care, is that integrated care doesn't then plug in, as I said, into the rest of what's going on locally, because that to me is where the value is. So I think if the NHS can work with its local partners to say, actually, this is the new balance that we require, then that's the way to go forward, as opposed to doing it on its own. And I think the better integrated care systems are in that space. But there's a big debate going on, because I know also that number 10 we know that number 10 is quite controlling at the moment, and that's not just COVID-19, that's generally. So there is this constant tussle, and as you know, Harry, there is always a constant tussle. And so one of the areas that I have been saying to the NHS is set yourselves your own jointly hold to account targets around inequalities. Don't wait for the DHSC or local or national government to set them for you. What do you think you need to set yourselves? How do you hold yourself jointly accountable to that, to yourselves, to your partners, and to the wider public? And that might be the space where we can actually get some more control, but also, frankly, clearer accountability. Because that is always a challenge around complex things like inequalities, is that we need to have stronger accountability as well as stronger support, in my view. And I might be a bit old-fashioned in that way, but I think the two go together.
Great. And maybe a quick answer to this question from Zara Coombs, saying you've talked about stalling life expectancy, but wants to know why we can't just be satisfied with it staying constant, which ought to be seen as a success. And that increasing life expectancy isn't necessarily a good thing unless the quality of life is sustained. So, you know, the disability-free life expectancy. Any comments on that?
I completely agree with the healthy life expectancy. So yes, we do tend to. That's just the headline statistic. Yeah. So quite right. I don't mean to imply that that's the only thing that's important. The only thing to say about that is we have had, you know, however many years since 1850 of increasing life expectancy. There is something about, are we reaching a limit? I think if we look at other countries, Japan is the one that everyone looks at. No, we're not at that limit yet. So we're not at a technical limit, which means there is a way to go. So should we be okay with that average? Then the answer is no, because we're not at the limit. Should we pay more focus to healthy life expectancy or disability for life? Absolutely. And as Matilda will know, having worked at the Institute for Health Equity too, that the gaps in healthy life expectancy are even wider than life expectancy. So it's about quality of life too, as well as length of life. And again, that's where the NHS can make a huge difference directly as an employer. Really interestingly, I think universities are ahead on this. University of Manchester several years ago looked at who it was employing and said it found it was employing nobody from Moss side. That wasn't acceptable to them, so they went out explicitly to employ people in the university structures from more deprived communities, and have made a big difference to people's lives and their health. The NHS can do that too. So the NHS has a role in the healthy life expectancy bit beyond treatment as well, in its broader approach to population health.
Great, thank you. So 2 very quick questions. I imagine the answer to this one is yes.
Yes.
Nicholas wants to know if you're including the education system in your work, and what schools can do to support population health at school and policy level. Good
question. So I think to some extent, it's a good question. We are, as the Kingsford can only do so much. So yes, it's on our radar, but we are, the focus of our work is in certain areas. So we've been doing a lot of work, as I was saying, particularly in the NHS relation to poverty. So there's something called, and you may be aware of this, called the poverty proofing the school day. And so actually some inspiration from the education sector. What would poverty proofing the healthcare day look like, for instance? So
Great.
actually
okay.
much
I'll
more
there, because we've got one more question and not very long.
Super.
Alexandra Gross wants to know how you think addressing obesity fits into this population health model.
It does. If you're interested in that, then listen to the briefing room with David Aranovich a couple of about a month or so ago, where I talk about the role of obesity. But the key thing for me, so my particular interest in behaviors is multiple health behaviors. So I think we pay too much, we need to, but we pay too much attention to obesity, to smoking, to alcohol, to etc. separately, when we all experience these multiply. So I think if I have a contribution to make on this one, it's actually to understand and recognize that people hold these behaviors in combinations, and what does that mean for policy and practice. And that connects to a population health approach about being much more holistic. And this is why I should make some praise for local government, because many local authority services are probably much more holistic than NHS services. They see people and say, actually, you're in poverty, you have a housing problem, you have a debt problem. That's why you're eating too much. It's your social problems which for you are leading to that. How can we help fix those, as well as help fix the health presenting problems, which may be obesity or other things?
I completely agree with that. I would actually go even further. I mean, I'm, as you may know, on a Lancet Commission with Chatham House, where we're looking beyond the common drivers of the non-communicable disease outcomes to common drivers of pandemics, non-communicable diseases, and environmental degradation. And actually, if you really get into it, some of the same, with inequalities and poverty at the heart of a lot of this, many of the same things sit under all of these problems.
Yeah,
and they manifest themselves absolutely in combination. So I think you're absolutely right there. That was really fantastic, Dave. I certainly learned something. I always do whenever I talk to you, even more when I listen to you. And I'm grateful to the people who asked a set of excellent questions, which meant I didn't need to do anything from my reserve list, which makes things even easier for me. So I'd just like to finish by thanking you again from all of us for your time and for such a fantastic presentation, and to all the people who joined us today. As I mentioned at the beginning, the session will be available as a podcast and online video in due course. I hope quite soon. I don't think it takes too long. I'd also like to thank Dr. Eleonora Fichera from the Department of Economics at Bath, who has put together this webinar series. We've got 2 more coming up in November as part of this series, and we'll tweet the link to the web page from the IPR Twitter account so that you can find that. And the details are available anyway on both the Institute for Policy Research and Department of Economics websites. So please do join us, and thank you again to everyone, and we hope to see you online again very soon.
Thank you very much, Harry. Thanks for the opportunity. Take care, everybody.
Thank you.